So I'm very happy to stand here. I feel like I'm the meat in an AHSN sandwich. And I'm very pleased to be in the middle of those two pieces of bread. And I'll explain why a little bit later. So before I start, and I'll hand over to Chris a bit later, 4 years. 4 years is the average delay to diagnosis for ADHD for children in the UK. So what that translates to is thousands of children each year starting with a compromised beginning in education. And as Chris, I'm stealing the words from Chris here, the diagnostic process for ADHD has changed very little in the last 20 years. And I guess I'm biased, but I think there is an opportunity now for technology to help, not to disrupt fully, but to actually help solve some of the challenges that are clinical, that impact many, many children and their families and adults. So what I will talk about is the project that Chris and I have been conducting to introduce QbTest and spread and adopt it into the East Midlands via the AHSN. Interestingly, the hotbed of research for our little company is actually the East Midlands, and specifically Nottingham University, who we've worked with for several years. So whilst we've helped to build our evidence base within the East Midlands, at the time of the mental health call that the organisation that Chris is part of the leadership team of, when that came at the end of 2015, there were actually 0 clinics within the East Midlands routinely using QbTest. And that was despite actually quite a high number of clinics already using it in that way across the UK. So it was a really nice fit for a mental health call to spread innovation and adoption. What is QbTest? I'll speak briefly about this. So it's a test that combines a sustained test of attention with infrared motion capture technology. It's used in the clinics, and it helps physicians to understand the level of symptoms of inattention, impulsivity, and hyperactivity. The benefits that we've seen in multiple audits are that you can speed up the diagnostic process, and that by doing so, you can release capacity and achieve some reasonable efficiencies within most of the clinics where we've taken a look at the impact. And overall, and I think I can agree with Nikki, it's important not just to get all of the propositions clear. You need a product that's needed, that fills a gap, but unfortunately it also has to deliver some significant efficiencies for any chance of adoption in the NHS. Nikki's helped me a great deal here. We could have thousands of bullet points on the slides. I'll pick on funding because I think the kickstart that we've had has been from the AHSN to fund throughout 2017. We're nearly at the end of the project now. 7 sites who had no experience with QbTest to adopt it, and also to help run the project to help them make good use of the technology. There's many implementation challenges around, how do you develop the staff and how do people change their pathways in order to make the best use of an innovation. And they shouldn't be underestimated, and we have a team dedicated to that. We've realized that's a really important part. And of course, evaluation, which Chris will talk about in a little bit of detail, is essential in order to justify ongoing spend in what is a cash-strapped NHS. And you'd expect nothing less. However, I think the biggest challenge is actually more of a cultural or systematic challenge. I'm not aware of very strong incentives for clinicians or managers to seek and adopt innovation. So we've built our business from the bottom up, and we have a very skilled team of people to do that. But it's a very slow method to spread an innovation that can really help both the NHS but also the patients. And frankly, without significant funding behind the organisation, we would have gone bust several years ago. So I think that's food for thought: is how could the system, apart from having mini AHSNs in every single NHS organisation, how can the NHS organise itself to incentivise some of those managers? So it's really only the determined ones that will adopt innovation. So we've had a great partnership with leadership, both clinical and managerial, from 3 of the trusts listed here. And without those leaders, we really wouldn't have succeeded with the project. Also with the AHSN and the input from our company. So we've achieved what we set out to do, which was for these organisations to make good use of the technology that was funded by the AHSN. And I would boldly say that each one of them has experienced improved care, and you would rightly say, well, show me the evidence. And I think we only have initial evaluation, so now it's time really to hand over to Chris, and his team are the ones running the evaluation of this project. Chris.
Thank you, Tony. Good morning, everybody. Yeah, I'm going to take on where Tony's left off to talk about this project, and he's talked a lot about evaluation. I think with so many eminent academics and researchers in the room, I'll have to put a caveat. I'm not talking about academic research. I'm talking about what do you need to do beyond the proving the clinical trials or other appropriate evaluation to prove the effectiveness of an app or a digital product. What do you need to do to help break down some of those barriers that Nikki outlined in terms of getting spread and adoption? Because I guess whilst most of the people in the room here are concerned with development, invention and research into new mental health treatments and technologies, I guess we all want to see these put into practice, not just left as research projects and nice academic papers. So I'm going to use the example of the Lincolnshire deployment, which is one of 3 deployments that the AHSN has been involved in of the QbTest solution, and to illustrate what's involved in taking things further forward. This follows on our premise for our involvement in projects is to base them on proven innovations. We put inverted commas around proven because exactly what that means varies depending on the type of innovation. But in this case, there was already an aqua trial conducted of the QbTest product to prove its clinical effectiveness and no safety issues, etc. So that was taken, so it works. Why aren't people using it? So we've been supporting the initial deployment. We call them demonstrators. I personally absolutely quiver at anyone mentioning pilots to do with projects. I don't know anyone else's experience, but the NHS and other health systems are littered with pilots, which some of them very successful, but because they were so focused on a beginning and end, even when they ended and were written up and were fantastic results, it then took another 2 years for someone to get the money to fund it to carry on. Meanwhile, it had been switched off, everyone moved on to something else, and you couldn't get engagement again. So one tip is never use the word pilot. Always start at the beginning, and always at the beginning talk about what you're trying to do. Assume it's going to be a success. If you've got the evidence that the basic technology works, then focus on how you're going to use the results of the demonstrator to get adoption and spread. So in Lincolnshire, we've got deployed in three sites there. It's been live since January. We've put some money in, but actually we've insisted on all the NHS organisations involved to put their resources, so they've had to invest from day one as well. We've not paid them for backfilling or anything like that. We've got an evaluation team which has collected data. We're in the middle of analysing now. Part of it is reinforcing some of the health economics work that was done as part of the aqua trial, but it's more real world evaluation, confirming where the savings actually occur, why some of the savings which were expected might not occur, looking at the other issues, how do clinicians like it, what changes to the pathway do you need to make, and all those other types of aspects. And most importantly, how do patients and their carers, or parents in this case, react to the use of the technology. In terms of numbers, the provisional evaluation results are very encouraging. The average time to first doctor appointment's gone down. That's probably more to do with some pathway changes that they've made rather than anything else. But key, the number of consultant appointments diagnosis has dropped dramatically. And that's key because that's actually what I cash releasing savings. Again, economics is great, but lots of people say this is going to have fantastic benefits and health economics of fantastic payback. Unless you can release cash to then hand over to Tony, in this case, to supply the technology, then you're not unlikely to get the funding unless you're in an area where extra funding is going in. And we all know that's not happening in many places in the NHS at the moment. And from a patient point of view, the reduction in time to diagnosis Tony's already talked about, that has fantastic benefits, but also longer term and wider economic benefits as well. And we're collecting a lot of qualitative feedback from the service users, parents, and also the clinicians. So those are the benefits. We're putting together business cases in association with the trusts involved. All three areas are already submitting business cases to continue the operation of the service beyond the beginning of next year when the initial funding from ourselves ran out. And we're looking to collect all that learning in a way which will then make it easy for other parts of the country, initially the rest of the East Midlands, but then working with our colleagues in Oxford and the other AHSNs to roll that out across the region and then the country. And so, I mean, our job, these demonstrators, is just the beginning for us. Our real job is when we get, and our real success is when we get technologies rolled out so that potentially the approximately 1 million children a year who need ADHD testing, so that we can dramatically reduce the waiting lists and the time to diagnosis for them. So, thank you very much.